So I'm going to go in the front this way. In the back, I would see these popliteal ligaments across the back. These are attachments for the gastrocnemius here. This is the popliteus, which I'm not going to talk about, which does a really cool little twist and turn. You know, when you stand up with your leg, your knee actually rotates as it locks. And in order to bend it again, you've got to turn it with the popliteus. So when you unlock your knee, you use this muscle to do that. That's bonus. You don't need to remember that for me. But you can see the bursa and stuff and the names of the ligaments on the back, and you know what that is. So if I want to go in the front, what am I going through? If I want to go in the back, what am I going through? All right, what everybody's interested in is what do I find on the inside? Okay, so let's learn the attachments of the major pieces holding this joint together. Okay, reminder first. Remind me. When we learn synovial joints, we learned that the bones don't really look like this, right? The bone here, the bony end of the femur, is not bone. What is it? It's cartilage. What kind? It's hyaline cartilage, articular cartilage. Same thing on the top of the tibia. What's more is the lateral and medial condyles of the femur articulate with the lateral and medial condyles of the tibia. What's the fibula for? Does the fibula bear any weight? It does not. The fibula is not a weight-bearing bone. So surgeons will use this to their benefit. You need a piece of bone somewhere? You got to get it from this person's body? This is where you go. Go get it from the fibula. You can borrow bony stuff there. It's not weight-bearing. So the weight here is femur to tibia. All right, this is the front view right here. And we've taken off the patella. We've removed the bursa. And we're looking at the ligaments. All right? Textbooks will categorize these ligaments as extracapsular and intracapsular. There are two major extra and two major intracapsular ligaments. What do I mean, my synovial joint experts, by the word capsule? What does that mean? If I injure my knee, does my lower leg swell up, my ankle swell up, or does my knee swell up? My knee swells up. If my knee is swelling, why isn't all that fluid down in my leg? Y'all remember this picture from last time? So we looked at a typical synovial joint, and I showed you the synovial membrane, and the synovial membrane lines a synovial cavity, right? It is a closed compartment. So when I say extracapsular, I mean the ligament is on the outside of the synovial cavity. When I say intracapsular, I mean that those ligaments are inside. So which one of these is more serious? Well, you've got to open up the cavity if you're going to get to the intracapsular ligaments. That's the more serious injury. All right, so let's learn them in turn. The first extracapsular ligament is commonly referred to as the lateral collateral ligament, or the LCL. Or we correctly call it, not just lateral collateral, we name it for its attachments, we call it the fibular collateral ligament. And as you can see here, it extends from the epicondylar surface of the femur down to the head of the fibula, the lateral collateral ligament. Now, what would you need to do, let's say it this way, what does the lateral collateral ligament prevent the knee from doing? Shifting laterally. That's as good a description as I can think of. It prevents the head of the femur from moving that way. So injuries to the lateral collateral ligament push from medial to lateral. The medial collateral ligament attaches out here on the medial epicondylar surface of the femur. Down here on the proximal end of the tibia, actually below the epicondyle. So the epicondylar surface of the femur down here to the proximal end of the tibia on the medial side. We call it the MCL. the medial collateral ligament, or more correctly, the tibial collateral ligament. Those are extracapsular. Those are the big daddies. Now, if you look at the articulation of the femur with the tibia, something else should jump out at you in terms of keeping the head, the condyles of the femur from moving medial and lateral. And they are the presence of these fibrocartilage pads that we call cingular meniscus. And there's one on the lateral side that butts up against the lateral collateral ligament in the capsule. So it pushes out of the capsule. It's in very close proximity. And one on the medial side that we call the medial meniscus. Now, it's important to note the anatomy of these two fibrocartilage pads. They are C-shaped, which means there's almost nothing. It's very thin in the center. So the lateral meniscus and the medial meniscus face the C, the body of the letter C is facing lateral and medial. The open part of the letter points toward the capsule inside the knee joint. So they're thicker. The meniscus are thicker in the C regions and thinner inside the capsule. So you can see how anatomically that would prevent lateral and medial movement of the knee. Now, the C shapes actually move anterior and posterior as well, and I'm about to teach you those ligaments. And so the meniscus not only help prevent lateral motion of the femoral condyles, but they also prevent anterior and posterior movement of the condyles. So anything that moves the condyles off of the tibia surface is likely to tear ligaments and also tear cartilage, because the thickened portions of these things hug the condyles of the femur to help prevent them from moving off of their articulation. All right, now we're ready. So I've moved from the collateral ligaments into the capsule now, and you can see passing through the intercondylar fossa are ligaments that attach to the condylar surfaces of the femur and to the superior portions of the tibia. These ligaments are named for their tibial attachment. Now, if you remember that, you won't get them confused. They're named for their tibial attachment. So the one on the front of the supracondylar eminence of the tibia is called the anterior cruciate ligament. Sorry, I pointed to the wrong thing. The one on the front is the anterior cruciate ligament, and the one that is attached to the back of the tibial intercondylar eminence is called the posterior cruciate ligament. Now, the word cruciate in anatomy means to cross. So these two ligaments, one attached on the front of the intercondylar eminence of the tibia and one attached on the back, pass through the condyles and cross one another. The anterior cruciate ligament crosses through and attaches to the lateral condyle, and the posterior passes through and attaches to the medial condyle. So, once again, the anterior cruciate ligament attaches to the anterior intercondylar eminence of the tibia and attaches to the lateral condyle of the femur. The posterior cruciate ligament attaches to the posterior intercondylar eminence of the tibia, and it attaches to the medial, posterior to the medial condyle of the femur. Now, what are their purposes then? So the purpose of the anterior ligament, as it passes through and attaches to the lateral condyle, is its purpose, its directional connection, is to prevent the knee joint from hyperextending. So as you come extended in your knee, the anterior cruciate ligament becomes tight. And the reason your knee joint will not continue to go that way is because of this ligament, the anterior cruciate ligament. It prevents the hyperextension of the knee. And since we know it is the primary player, it is really the ligament that prevents this from happening, checking for injuries of the anterior cruciate ligament are quite simple. They're quite simple. And you guys have probably seen it on the football field. You've seen it on the soccer field. You see the athlete taken over to the table. They can actually do it while they're laying on the field. Has anybody had this done to them? So they take the pressure off your leg, right? They get you where your weight's not on it. And then the orthopedics takes your bottom leg and does what? What do they do? What? So this guy is attached. Look at where it's attached. It's attached to the front of the tibia here, right? And it is attached to the back of the lateral condyle. So what should you not be able to do? With the femur, you should not be able to do this. Which direction should the femur not go? Back. Y'all see it? It should not go back, which means the tibia should not go forward. That's what they did with your leg. They took the weight off of it, right? And they put their hand behind your knee like this, and they pulled on the tibia. And if it gives and comes forward, then the season is over, right? Your anterior cruciate ligament has been torn. It's a real simple little test you can do. Just take the weight off the leg and you can do it. Now, one of the most beautiful things about today's surgical world is this is a very common sports injury. I dare say there aren't very many people in this room who don't know somebody who's had an injury to the ACL. Is that true? Most of you know somebody who's had this injury if you haven't had it yourself. The surgery today is a remarkable one. And the surgeon who replaces the ACL is not going to mess around in here. Have y'all seen this procedure? They're going to drill with this massive bone drill. They're going to drill a hole through just inferior to where this medial collateral ligament is, this tibial collateral. Drill it through the tibia here, through the capsule, and up through the femur on this side. And they'll put an anchor here and an anchor here to create a new anterior cruciate ligament. That's cheating, yes? They put a massive ligament in here that roughly represents the same attachments for the ACL. But the difference now is going to be it's a much more massive piece of tissue and it runs a longer distance. It's stronger than the other one. So in today's world, you can ask these athletes, once they've recovered, the knee that has had surgery on it will oftentimes be the stronger knee because of this ACL procedure that they do now. It's remarkable. I have watched a couple of these procedures on video. I've never seen one in person, but it just always amazes me the way they treat people's legs, you know, in surgery. Take a massive cut across here and open all this up, and then the surgeons, you know, got this drilling through the bone to replace the ACL. Has anyone in here had this surgery done, an ACL surgery? Nobody in this room has had ACL replacement. You've had yours replaced. Yeah? You got a big, massive, nasty scar on your knee? Which knee is it? The right knee. And what can you say about the recovery? Do you feel okay? Is it better? Is it worse?
It's worse.
It's worse. So yours is not, it's not as strong as it was.
My daughter said the same thing.
Your daughter's is not as strong as it was.
She still has a
Do you have scars high on your femur? Where the Yeah, look at that scar. And you can see where they drilled through the tibia there. Yes? There's a scar. Yeah. 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 Huh. Interesting. But it still bothers you. Wait till you get old. It's not encouraging, right?
That's not encouraging.
Yeah. Okay, so this is the most common one. I like to pause there for just a moment and let kids think about it with me. The posterior cruciate ligament is a ligament that really prevents, can you help me? Look at its attachments. The attachment of the posterior cruciate, the PCL here, is on the posterior aspect of the tibia. It goes through toward the front and attaches to the medial condyle. The posterior comes through from the back of the knee and attaches on the medial condyle of the femur. Now, what does it prevent from happening? When does it get tight? Is it tight now? So when I lift my legs up this way, does the PCL go tight? No. How do I tighten it? With flexion, exactly. So when I flex my knee like this, now I'm tightening up the PCL, yes? So really, to damage this ligament, what do you need to do? Overflex. So y'all have seen some of this too, this horrible vision of the guy being tackled and this part of his leg comes all the way up here and he tears the PCL. It's more common from the front, right? That injury where the contact comes here in the front and you get hyperextension that tears the ACL. All right, so here are the bones, the patella, and the pieces we've been talking about, the tibial tuberosity, and the medial and lateral condyles and the condylar surfaces, and the intercondylar eminence. I say, what would be attached to the posterior aspect of the intercondylar eminence? The PCL. What would be attached to the anterior aspect of the intercondylar eminence? The ACL, yeah. So there's the head of the fibula and the bodies. Now down here on your feet, the medial malleolus or malleolus, depending on which anatomist you learned it from, is what you think of as your ankle bone on the medial side. That bony piece right there is the tibia, and the lateral one is the fibula here at the end. Now, I have 5 more minutes of lecture to do with you because I wanted to do one more thing with you. I'm going to wait until Friday to do it. I want you guys to be studying for your exam. Your exam is on Monday, right? Okay, so I'm going to, in an effort to warm you up, to warm up the conversation on Friday, I'm going to finish with the feet. It won't take me long, right? The calcaneus, the talus, the cuneiforms, the cuboid, and the navicular. I'm going to put a couple of muscles on it. I'm going to mention the calcaneal attachment to the lateral medial heads of the gastrocnemius and the triceps surae. And then one last thing, I'm going to say, look, at this muscle is named an extensor, but there is no such thing as extension in the joint movement. So I can say something about the joint again and get the question started. This will be, as we begin class on Friday, I'm going to do feet. Then you will have the rest of the class to ask any question that you would like to ask about your exam on Monday. Friday is designated review day for anatomy and physiology. Does anyone have any question about what is happening now? Yes, ma'am.
You learned all the extensors?
No. No. I'm just going to do a couple. I just want to make the point, doesn't it seem weird that we call it plantar flexion when the muscles are called extensors? That'll help you remember it. Now, what are you doing with the muscle attachments? Are you learning muscle attachments? You're learning origins and insertions, right? Okay, so these are questions nobody should miss, right? I'm going to have on your exam, there will be 10 multiple choice questions, all in a row. And the question will say muscle and 4 attachments. And you pick the right one. It's not fill in the blank, it's multiple choice. I'll have the muscle name and the attachments. You pick the correct attachment for the muscle. 10 questions on the exam. Where are you getting that information? Right. I put the muscle list for you on the portal. Yes? And what else have I done? I've been teaching them to you in here, right, as we've gone. Now, there are a few of them that I didn't teach. So you need to do those. Yes?
Are you just saying the 10 specific questions, or are you saying there's only going to be 10 questions?
No, no. There will be 10 muscle questions. And then I'm going to have 65 additional questions about bones and joints and ligaments and all that kind of stuff. Y'all, we haven't had as many class periods, but there's a lot of information on this exam. So come to class on Friday ready to ask me questions.